Breathing circuits form the backbone of anesthesia delivery. We welcome Dr. Anand Bangera, Professor, Department of Anesthesia, K.S. Hegde Hospital, Mangalore, to simplify and demystify these systems.
I skipped, and Sam and Shalu madam, they don't excuse me if I don't come, so that is why I had to come this time. The second thing is, after a very detailed discussion about anesthesia machine by Dr. Gurudat sir, who is my guru, the Shishya's talk may not be that effective, and I will not definitely go in depth. So I will talk little the most basic things. Yeah, before I start, let me ask you one question. Which breathing system you use when you induce a patient for general anesthesia? Commonly. Which system you are using? Which breathing system you are using? All are using circle system only. Yes, I understand. Even in our institution nowadays, people use circle system. Yes, if circle system is not there, you go out and practice as a freelance anesthesiologist. Which system, breathing system you use? Keep aside the circle system. Bain circuit. Yes. My next question is, what is the flow that you keep? Can you answer? What is the flow that you keep? No. What is the total flow? Not in terms of so many times and all. For pre-oxygenation. Yeah, if you are keeping anything above 10 liters or 15 liters, that is correct. But the ideal circuit or the breathing system for pre-oxygenation would be? Ideal would be the Mapleson A system or the McGill system. And that is the exact reason why you should know little more basic things about breathing systems. Yes. Now, what exactly is the breathing system? You can define it simply as an assembly of components which connect the patient's airway to the anesthesia machine, creating an artificial atmosphere from and into which the patient breathes. That is the definition for a breathing system. Now, we usually use the word breathing circuit. Okay? The correct word is breathing system. Why not breathing circuit? Because these Mapleson systems are not the complete circuits. Only the closed circuit is the complete circuit. That is why if you are using this word in common for all the breathing equipments, then you should call it as breathing systems. Okay? Now, see, when anesthesia was started, when Morton started anesthesia, or when anesthesia was given with open drop anesthesia, there was no requirement for a breathing system. All requirements started when they started using gases. Okay, either it is cyclopropane or nitrous oxide or life-saving gases like oxygen. They even used carbon dioxide during anesthesia. Can anybody tell me why they used carbon dioxide? Little about history. Those days there used to be 4 tubes here. They used to use carbon dioxide just to stimulate respiration. So that is why the requirement for a tubing system and a breathing system started. So when McGill started his McGill's endotracheal tube, so in the year 1917, he started the McGill circuit, which we now call it as a Mapleson A system. Unfortunately, now it is not at all used. I wanted a McGill circuit. Unfortunately, different types of Bain circuits have been brought here, not the McGill circuit. Okay? For different reasons, it is not being used now. Then the Ralph Waters, he introduced this to and fro system, which was used during the introduction of cyclopropane, and also it became very popular when there were cases of open tuberculosis, so that with this the canister could be sterilized very easily and preventing the cross infection. Now later, this part in the year 1936, the circle system is introduced. That is the most popular system now, which is being used everywhere. After that, there were no specific breathing systems, especially for pediatric patients. That is why this Ayres in the Philip Ayres in the year 1937, he brought this Ayres TPs, and then this Ayres TPs was modified by Jackson and Rees, which we now call it as Mapleson F circuit. Okay, so this is a little detailed history about the breathing systems, but I am not going in detail for the lack of time. Now, what are the basic components of a breathing system? See, it should have a fresh gas entry port, a port to connect it to the patient's airway, and a reservoir for gases, and then a expiratory port. These are the most basic components of a breathing system. Now later, we added a carbon dioxide absorber, a EtCO2 sensor, and a humidification system, and also flow directing valves and different advanced types of corrugated tubes. Those are what are the requirements of a breathing system. You can further classify these requirements as essential requirements, which is very much required. It should deliver the gases from the machine to the alveoli in the same concentration as set in the shortest possible time. In the same concentration and also in the shortest possible time. And it should effectively eliminate carbon dioxide. There should be minimum apparatus dead space, and it should not create much resistance. The resistance should be as low as possible. Then what are the desirable requirements? It should be economical, and it should allow low fresh gas flows, which we are practicing with the low flow anesthesia. As far as possible, it should conserve heat. It can add some amount of humidification of inspired gas, and it should be lightweight, so that if the weight of the circuit itself is more, there is a chance of disconnection, which sometimes may not get noticed. Okay? Other desirable requirements are, it should be convenience during use. See, when if you are not using closed circuit, if you have the option, the Bain circuit is the most convenient, because you can hold the reservoir bag according to your convenience. Whereas if you compare it to McGill circuit, the reservoir bag is very close to the anesthesia machine. It is quite difficult to ventilate the patient. Okay, it should be, the breathing system should be efficient during spontaneous as well as controlled ventilation. Ideally, it should be you should be able to use it for pediatric patients as well as adult patients, and it should not create theater pollution as much as possible. Now, to classify the different breathing systems, there are different people classified breathing systems. This is the most initial classification, Drips classification. He classified it as insufflation type, open breathing systems, semi-open breathing systems, semi-closed breathing systems, and closed systems. It is little confusing, is it not? Technically, a semi-opened and a semi-closed things are almost same. Is it not? So that is why not very, this particular classification system is not used. But what we can remember is, you know about the closed circuit. If you keep the APL valve little open, you can call it as semi-open system. All other Mappleson's breathing systems, you can, Mappleson's breathing systems you can classify as semi-open, and if you slightly open the APL valve, you can call it as semi-closed system. So that is not very important, so don't bother about that. Then we have the better classification system introduced by McMahon. He classified simply as open, semi-closed and closed. In open system, there is no breathing, no rebreathing at all. In semi-closed system, there is partial rebreathing, and in closed system, when it is totally when the APL valve is totally closed, there is total rebreathing. Total rebreathing means eliminating the carbon dioxide, without carbon dioxide. Now, this is one better system of classification introduced by Conway. He just classified it as breathing systems with carbon dioxide absorber and breathing system without carbon dioxide. Now, based on the position of the reservoir bag, you can classify as afferent reservoir systems and efferent reservoir systems. Mapleson A, B and C are afferent reservoir systems because the reservoir bag is on the afferent side, whereas D, E, F, the more or less TP systems are efferent breathing systems. Okay. Now, this particular reservoir bag, the most important component of a breathing system, which nowadays is not made much use of. It has so many functions, so you should know the functions of reservoir bag. You should make use of it because it serves as a reservoir of gases to provide peak inspiratory flow during spontaneous breathing. That means, what is the capacity of a adult reservoir bag? Around 2 liters. That means that 2 liters should provide adequate fresh gas flow even if the patient takes a deepest inspiration. That is what is called as peak inspiratory flow. So for an adult patient, the capacity of the bag should be around 2 liters. It gives you should be able to assess the breathing when the patient is breathing spontaneously, or you should be able to control the ventilation. Okay. It gives you a visual and tactile assessment of the patient's rate of respiration and depth of respiration, especially during spontaneous breathing. That is why when you induce the patient, when you hold the mask, you have to look at the patient's reservoir bag, especially if you don't have a EtCO2. Yes, EtCO2 is a very useful device, but the EtCO2, to get a good EtCO2 measurement, it takes little time. So you should be able to recognize that derangement using a reservoir bag much early as possible. That is one advantage of a reservoir bag. And it provides a buffer. Okay, even if there is some kinking of the tube or kinking of the circuits, even if there is obstruction, this reservoir bag should expand and should prevent barotrauma to the lungs. Okay, and next component is the APL valve, adjustable pressure limiting valve, or simply the expiratory valve. The purpose of these valves is to allow the escape of exhaled air and surplus gases from the breathing circuit, but without permitting entry of air from outside during a negative pressure. So it should act something like a one-way valve. The expired gases should come out, whereas the inspired gases the outside gases should not come in. The expiratory valve, which is attached to a McGill circuit, is called as, have anybody seen that particular valve? the metallic valve. It is called as the heat brings valve. Okay, it is a very special type of valve. It works only when the expiratory valve is kept upright. If you keep it on the reverse side, it will not act. There will be rebreathing. Okay. So the pressure required to open the valves must be as low as possible in order to minimize the resistance to expiration, but sufficient enough to prevent the reservoir bag from emptying spontaneously. That is about expiratory valve. These unidirectional valves, where are these situated? These are situated only in the closed circuit, not in any of these Mapleson circuits. These are the complete unidirectional valves. There is one valve on the inspiratory. There is one valve on the. Can you focus here? That is. This we are going to discuss in a little more depth later when we are discussing. Yes. Yeah. So you need one on the inspiratory side and one on the expiratory side. So it prevents rebreathing also. Then the tubings, the earlier tubings which were available were in black color, made up of rubber. And why it is black in color? In those days, carbon was added to the rubber. It is mainly to prevent generation of antistatic electricity. Nowadays, it need not be black because we are not using any inflammable anesthetic agents. But the disadvantage of corrugated rubber tubing is it is quite heavy. There are some advantages. The length is always 110 centimeter and diameter is 22 millimeter. If you want to appreciate this, you should get a Magill's A circuit, Magill circuit or Mapleson A circuit. Is there do you think that Mapleson A circuit or Magill circuit should come back? I think that it should come back. Where it should be useful? A Mapleson A circuit with a plastic tube without much weight should be ideal for patient on spontaneous breathing when you introduce a supraglottic airway device. Is it not? Many a times we connect the supraglottic airway device into a Bain circuit and we keep around 6 or 8 liters, and that is definitely not enough when the patient is on spontaneous breathing. So the ideal circuit when you introduce a supraglottic airway device, which many a times we practice, is it not? Should be a Mapleson A circuit. So there should be a role for Mapleson A circuit. Some company should think of it and the Mapleson A circuit can come back. Okay. The tubing should be flexible and should not kink. That is why they are corrugated, and it should be able to trap moisture and prevent it from going back to the apparatus. Transparency is desirable. The advantages of these tubings being corrugated is it is kink resistant. It can expand to some extent so that it can act as a reservoir, and it can also be reused. Whereas the present day disposable plastic tubes, because they are relatively transparent, you can make out the patient's expiration. And what are all the disadvantages of the rubber tubings are the advantages of plastic tubes. Like these are light, and chances of disconnection is also less. Silicon tubes are also quite heavy, so chances of disconnection are little high. That is why disposable, these plastic tubes are very popular nowadays. Now, some terminologies are important here. Rebreathing. Okay, the rebreathing depends on, in these systems, it depends on the fresh gas flow rate that you keep. design of the breathing system, mode of ventilation, whether it is spontaneous breathing or controlled ventilation, patient's respiratory pattern, whenever there is a tachypnea, it gets affected, and also mechanical dead space. Effects of rebreathing, I am not going to discuss. Patient dead space and anatomical dead space, I am not going to discuss in detail. Now, we shall discuss a little more in detail about the Mappleson's breathing system. Mapleson, in the year 1954, he classified these semi-closed bar, semi-open breathing systems into, he initially classified into 4, then later TPs was added, and finally Mapleson F was added. So later T and F. Now this is commonly it is asked in the exam. Either a McGill circuit is given or a Bain circuit is given, and then you are asked to explain. So how you can remember here is, see, as I told, okay, there is no pointer. Okay, see. There is that triangular thing that is shown is the face mask in the first one. The next you have a expiratory valve, then we have a corrugated tube, then we have a reservoir bag, and the arrow mark that I have shown is the fresh gas flow. So here the expiratory valve is near the patient, fresh gas flow is away from the patient. Expiratory valve is near the patient, fresh gas flow is away from the patient. This is Mapleson A. Okay? The reverse of this, what is reverse of this? Which system there is reverse of this? Yes, reverse of this is Mapleson D. See there, the expiratory valve is away from the patient and the fresh gas flow is near the patient. So you can remember like this. So Mapleson A and Mapleson D. It is clear, is it not? In Mapleson A, the expiratory valve is near the patient, whereas in Mapleson D, the fresh gas flow is near the patient. Now what about B and C? In B and C, both expiratory valve as well as the fresh gas flow inlet, okay, both are near the patient, B and C. You can make out, no? Only difference is in Mapleson B, I think it is little reverse. In Mapleson C, they have added a corrugated tube. Initially it was not there. Now as I told, Mapleson E and F are a TP system. Mapleson E is just a Ayers TPs, whereas in Mapleson F there is a corrugated tube attached with the reservoir bag, and in the end there is a leak. Initially there was just a leak. Now when you want to control the ventilation, you can add a expiratory valve and you can control the patient's breathing. So this is the basic structure of different breathing systems according to the Mapleson system. Now, so as I told you, efferent reservoir systems, Mapleson A, B and C are efferent reservoir systems. Efferent reservoir systems work efficiently during spontaneous breathing, whereas the efferent reservoir systems work efficiently for during controlled ventilation. Yes. Now, ranking of Mapleson systems based on superiority when you compare for the best one for spontaneous ventilation and best one for controlled ventilation. For spontaneous ventilation, the best circuit still even now is Mapleson A or McGill circuit, and for controlled ventilation is D, Mapleson D. Bain circuit is a modified Mapleson D. Okay? So this you need to by heart. For spontaneous ventilation, best is A, next best could be D, F, E. Whereas for controlled ventilation, best is D, next is F, next is E, and the least could be Mapleson A. Now, advantages of Mapleson's systems compared to a closed system. These are quite simple. If you see, look at the closed system, it looks quite complicated, whereas Mapleson systems are simple, lightweight. I'm talking about even the McGill circuit with a disposable plastic corrugated tubes. Inexpensive parts, low resistance, low dead space, and all parts can be easily cleaned and sterilized. Even if there is a disconnection anywhere, you can immediately make out and you can reconnect it and connect it. The disadvantages are high fresh gas flows are required, so hence there is wastage of gases and works out costly. Elimination of carbon dioxide depends on the fresh gas flow. Only if you keep a higher fresh gas flow, depending on the type of breathing circuit, you can control the carbon dioxide level. And loss of heat and humidity. This is in compared to closed system. Now, if I have to do a functional analysis of this Mapleson systems, you have to go through this. See, Mapleson made some assumptions for functional analysis. The assumption is like this: the gases move en bloc. That means they maintain the identity as fresh gas, dead space gas, and alveolar gas. And there is no mixing of this. So the reservoir bag continues to fill up without offering any resistance till it is full, when the expiratory valve is partially open. The expiratory valve opens as soon as the reservoir bag is full and pressure inside the system goes above the atmospheric pressure. The valve remains open throughout the expiratory phase without offering any resistance of gas flow and closes at the start of next inspiration because of the negative pressure. Okay, this you should assume. So when you are doing a functional analysis. Now, Mapleson A system, it is the McGill circuit. It is best suited for spontaneous respiration, and this is the only system in which the fresh gas inlet is away from the patient. Now, when the patient is on spontaneous respiration, what happens? As the patient, first thing consider during expiration what happens. As the patient exhales into the circuit, the dead space gas first enters the circuit, followed by the alveolar gas, because it is close to the expiratory valve. Simultaneously, the fresh gas flow from the other end is entering the circuit from the machine and is filling up the reservoir bag. This you should think. Actually, the gases are flowing from both ends. From one end, patient's expired gas, and from the other end, the gases, that is the fresh gas flow. When the bag is full, the pressure in the system increases enough to vent out the gas to the atmosphere through the open APL valve when the bag is full. Thus, alveolar gas and part of the dead space gas is vented out. This is provided there is sufficient fresh gas flow. Now, during inspiration, the first gas that the patient would be breathing is the dead space gas. Okay? Followed by, since all alveolar gas and part of the dead space gas is vented out of the circuit during expiration, the next gas breathed will be the fresh gas flow. Okay? The alveolar gas is breathed in only if the fresh gas flow is low. Here, the fresh gas flow counts. If the fresh gas flow is not sufficient, there will be rebreathing. Patient will be rebreathing his own carbon dioxide contained gases. Okay? So, during controlled ventilation, what happens? The APL valve is partially closed and the pressure in the breathing circuit during expiration is low. So, no gases escape through the APL valve till the reservoir bag is distended. Dead space gas and the alveolar gas remain in the circuit, and part of the dead space gas and alveolar gas may reach the reservoir bag. During early inspiration, the pressure in the circuit has not increased enough to open the APL valve. The APL valve remains closed and the patient breathes in the alveolar gas. The pressure in the circuit increases due to squeezing of the reservoir bag and the APL valve closes. So that is the difference between the inspiration and expiration. During this phase, part of the gas is vented out and part of it enters the patient. Thus, there is a possibility of rebreathing of alveolar gas venting out of the fresh gas. But because you are pumping the gas, the fresh gas flow required is quite less compared to when the patient is breathing spontaneously. That is the difference as far as the functional analysis of these systems. So this I don't have to tell again and again. The Mapleson CA is best for spontaneous breathing, and it is economical only when you leave the patient on spontaneous breathing. Disadvantages, see, that is the last one that I was discussing about. That is the heat brings expiratory valve. If you keep it reverse, it will not work. That is the McGill circuit. The lax circuit is simply what is the difference between lax circuit and Bain circuit? What is Bain circuit? Bain circuit is a coaxial modification of Mapleson D. The coaxial modification of Mapleson A is lax circuit. Since lax circuit is also not very popular now, we shall not waste time in discussing about lax circuit. Mapleson B and Mapleson C is not being used. Mapleson B, both fresh gas flow as well as the expiratory valve is near the patient. Okay. Mapleson D system, the Bain circuit is the coaxial modification. Here, fresh gas flow is near the patient and expiratory valve is away from the patient. The fresh gas flow inlet is at the patient end of the circuit, and both the APL valve and the reservoir bag are at the machine end. A corrugated tube connects these usually at around 1.8 millimeter in length, and one particular thing that I want to show about I hope you all have seen at least Bain circuit. You know which is the inspiratory limb and which is the inspiratory limb and which is the expiratory limb? At least you can identify with the color. I don't think there should be any confusion. Inspiratory limb, this is the inspiratory limb, okay? You may get confused. See, that is the patient end, this is the machine end. You may think that the inspiratory limb is away from the patient. Actually, it is going inside, but it is opening here, near the patient end. That means the inspiratory end or the fresh gas flow is near the patient. It is not away from the patient. What is away from the patient is the expiratory valve. The other thing is the common area where it kinks is here. Okay? Here it commonly kinks, so that is why many a times you may have to do like this and you have to put a plaster here. This is more the one practical thing that you should know. Whoever uses a Bain circuit, usually it gets kinked here. It becomes like this. Okay? So, what are the advantages of Bain system? Without going the slides there, can anybody tell me? It is ideal for it is ideal for controlled ventilation. Then it is lightweight. You can increase the length. You can increase the length of the corrugated tube. So you can, this was initially very popular circuit for head and neck surgeries, maxillofacial surgeries, ENT surgeries, and also neurosurgeries. We are talking about the era where your closed circuit, all those things were not there, because McGill CA circuit, you can't stand very close to the patient's head. Then any other, this can humidify the gases. These are all the advantages of McGill circuit. Yes, that is why this is called as, because you can use this for spontaneously breathing patient as well as controlled ventilation, and for pediatric as well as adult patient, this is called as the universal circuit. Okay, functional analysis of Mapleson circuit I will not go because of the lack of time. So the fresh gas flow that you should keep, you should know very well. You can use this for a pediatric patient, but not very ideal. So if it is less than 10 kgs, at least around 3 liters should be there. And if you are using this for spontaneous ventilation, 2 to 300 ml per kg should be there. Okay, advantages and disadvantages we have discussed. Mapleson E-piece is simply a T-piece system which was initially used for pediatric patients. Those are the dimensions. Okay, then Jackson and Rees added a corrugated tube and a reservoir bag. Okay, this is IS T-piece and the Mapleson F circuit we have already discussed. Okay, functional analysis of Mapleson F is very much similar to Mapleson D, so we need not discuss because of the lack of time. So these are the recommended fresh gas flow. If you are using Mapleson A, it should be 70 ml per kg per minute for spontaneous breathing. If you are using it for controlled ventilation, it should be 2 to 3 times the minute volume. Okay, for Mapleson D, if you are using it for spontaneous breathing, that means it should be 3 times the minute volume. If you are using it for controlled ventilation, just equal to minute volume is enough. Mapleson F around 2 times or 2 to 3 times the minute volume for whether it is spontaneous or for controlled ventilation. Okay, circle system, these are the components of a circle system. 48 mesh size means if you can divide a square out of an inch, and you further divide it. Okay, if you have 2 meshes, one wherein each square inch is divided into 8 parts, and in one more wherein you divide each square into 4 parts, these granules should pass through 4-sized mesh, but it should not pass through 8-sized mesh. Why is this size is important? Because the carbon dioxide passes through the intergranular and intragranular spaces. If the size is very less, there will be close packing of the granules, so efficient carbon dioxide exchange may not be there. Other important thing where you measure or assess the quality of the granules is in terms of hardness numbers. Okay, there should not be powdering of the gas. The hardness number is measured in terms of, usually it should be more than 75%. That means these soda lime granules are thawed in a pan containing steel balls. and after some time, if you around 75% of the granules should be intact. If less than 75% are intact, that means there is more powdering. If there is more powdering, one thing is there will not be effective gas exchange. Second thing is patient can inhale. Okay, it can produce some chemical things. So that is also disadvantage. Okay, this is the reaction that I have explained you. So advantage of circle system is economy of fresh gas flow, reduced operating room pollution and conservation of heat and humidity. Disadvantage, extreme caution with inspired concentration of gases required. Okay. Possibility of incorrect arrangements because there are so many connections, and also possibility of dangerous gases like carbon dioxide, all those things, and difficult to clean. These things will not. Only one thing that I forgot is the checking of a vein circuit that is usually asked in the exam. How to check the integrity of a vein circuit? Can anybody tell me? There are two tests. One is the Pethick's test and the other one is finger occlusion test. Okay, how Pethick's test works? What principle on what principle? It works on Bernoulli's principle. Can anybody tell me how Pethick's test is done? Okay, you connect the fresh gas flow. Okay, fill the reservoir bag. Okay, then simultaneously, initially you should close the patient end, and then simultaneously you on the flushed, oxygen flushed, and then leave the patient end. What should happen? Normally, bag should fill or collapse? Bag should collapse because of the negative pressure that is created in the expiratory limb. The bag should collapse. What if the bag fills? If the bag fills, that means the integrity of the inspiratory limb is lost. Either there is a leak or it is disconnected there. The other test is finger occlusion test. I think the important aspects I have covered. Any specific question is there? If there is time, you can ask. Thank you very much, and thank you very much for the patient hearing and the opportunity.
Thank you, sir, for this wonderful session.